Thank you very much, Dr. Jha. I must say I completely agree with what you said about a good history. Um, I've been practicing foot and ankle surgery for a number of years now, more than 10, 12 years. And over the years, that I find myself examining less and taking history more. So that's what I meant. On the screen here, you can see a picture of my hospital. So I am working in Glasgow. That's the Golden Jubilee Hospital. This is the river called Clyde. And this is a beautiful, beautiful campus of the hospital. This is where I met Dr. Ashish in 2014. Just on to the right side of this hospital, there is a helipad. It was designed to bring Arab patients over to Scotland for treatment. Um, After I saw Ashish's hospital, I thought there is some similarities here. So this is your river, Ganga. That is probably Anup and Savera Hospital. And I think the helipad is on the way. Right, Ashish? Is he here? So I have traveled from Glasgow to Bihar. And does anyone know what that blue dot, where the blue dot is? That's my home city. It's Baroda. It's in Gujarat. So foot and ankle, I was asked to speak about foot and ankle examination, and I understand that it is, I would say it is developing across India. In the Western world, it's widely recognized as a subspecialty because we get patients who would come and seek a foot and ankle surgeon. The patient would go to the general practitioner and say, I need to see a foot and ankle surgeon. It's not the same here, I know. But it is, as I said, it's a very fast developing subspecialty here. And it has a very vast spectrum of pathologies and treatments. If you want to compare insurance codes for hip and knee in foot and ankle, there will be about at least 25 procedure codes. You can compare that with your arthroplasty codes. I just want to start by highlighting a case. It's a patient of a patient for a knee replacement. So this patient has osteoarthritis. Patient gets a knee replacement. And at 1 year follow-up, patient is still having persistent anterior knee pain, normal markers, and it's interesting to hear about D-dimer from the earlier speaker. Patient gets a CT scan to look for any malrotation of the components. There's no malrotation. And now the patient is complaining of ankle pain and then gets referred to me. And I always make it a habit to examine the patient from the knee below without socks and shoes. And on his left side, we can see that patient has a cavus foot. And that was his X-ray. So, if I can say a lesson for residents, always remove socks and shoes whenever you are examining any patient with a lower limb pathology, even if it's a hip. And always examine the patient in a standing position because you want to look at the alignment, as in the previous case we just saw. Rolled up trousers or sari, and keep the hind foot alignment in view even when you are seeing the patient for a knee replacement. Going back to that case, that patient had a varus deformity, quite a severe varus deformity, and there was no way of salvaging it without fusing it. So that patient gets a hind foot fusion with a nail, and that settles the anterior knee pain, and the patient's mobility improves. So the point I'm trying to make here is that always look for hind foot, even if you are planning your TKR. And I started looking at the hind foot. From following that case, I started looking at the hind foot alignment, and I found a pattern from my observation. If you have a patient with a varus knee, as in this case, and again, this is varus knee. This is as bad as it can get in the Western world, not the varus knees that you see. But in this patient, what we see is if you drop a plumb line going through the heel, then on the left side, that plumb line is not bisecting the heel, i.e. the patient has a flat foot or a valgus hind foot. And the opposite, if you see somebody with a valgus knee, then you find that the hind foot is curved inside. And this is all to balance. So you will, if you start seeing it, you will see this pattern in a large number of your cases. Valgus knee, varus hind foot, varus knee, valgus hind foot. So I asked myself a question that should the alignment of the long leg not be measured up to the heel? Because at the moment it is only measured up to the talus. That is your mechanical axis. Moving on to the examination part, there's two parts, hind foot and forefoot, if I can divide it into. And again, as Dr. Shah has said, history, very important, examination. And in most cases, you can make a reasonable plan based on weight-bearing x-rays. So it's very important to have weight-bearing x-rays. Any of my fellows, if he ever refers somebody to me with a non-weight-bearing x-ray, I would refuse to give an opinion. In terms of hind foot, there are three main shapes that we need to be aware of. So starting from right to left here. So this one is varus. This is in between, so it's called subtle cavus. And this is valgus. So valgus, subtle cavus, and varus. And it's very important to know this. So we all know what a flat foot or pes planus looks like. So that's what it looks like from the side, from the back, from the front. That's your pes planus. And I'm sure you are familiar with this because this is very common. I see a lot of people on the street walking with pes planus. When it comes to subtle cavus, it is not easy to spot, but it is very important to spot because this patient here is standing, we look from the front, then we are able to see just about a portion of the patient's heel from the front. And it's called a peekaboo sign, which means that when the patient has a normal alignment of the hind foot, you would not be able to see the heel. The heel will be hidden behind the ankle. So, but what it means is that the hind foot has turned from normal physiologic position of 10 to 15 degrees of valgus and has become into a zero position. So that's like 10 degrees of turning of the heel. That's why it's very important because these patients have their own set of problems. So again, this is the middle part is here where the heel is directly under the tibia, which is not normal, is what this patient is having. And the third alignment is the cavus. Again, I'm sure a lot of you would be familiar with identifying these because this can be quite severe. It's also common. And again, on this picture, it is this alignment here, which is inside from the tibia. Once we know the shape of the hind foot, we want to know whether it is mobile or stiff. Simple. And then moving on to the forefoot, we want to again look at the shape, again in a standing position, looking from the front. And there can be either a planus shape or physiological shape, which is like normal, or you can have adductus. We want to know the length of the first metatarsal, which is very important. And we want to know if the small toes have any deformity. So moving on to the shape, so this is the planus foot that you can see from the front. This is the adductus foot that people who practice pediatrics would be familiar with this shape, the bean-shaped foot that grows into an adult if it is untreated and turns into this. So this is called metatarsus adductus. And then obviously you have the arch, you have normal arch, flat arch, and high arch. The metatarsus adductus is significant deformity and causes lots of problems. If you try to put this foot into a shoe, it will not work. There is no shoe in the market that can accommodate it. So if the patient needs to wear a shoe, they will need your help. If they're going to wear sandals or slippers, they will manage. The X-ray, if you take, would look like this. And just for reference, that's a normal X-ray. So here, first metatarsal is pretty much parallel with the other metatarsals. and that's normal. In this case, first, second, and third are leaning inside, so it is adductus. 4 and 5 are straight. The length we spoke about, is it short? So the short metatarsal would look like this. And if you started looking in your family and friends, you will find somebody with that kind of foot shape. Is the first MTP joint stiff? That's what a stiff joint would look like. It's not very easy to appreciate from this picture. And whether the first TMT joint, which is significant joint, same as the CMC joint in the hand, whether it is hypermobile. So first metatarsal being short, clinically it would look like this. If you took an X-ray, it would look like that. And if you draw a line, then you will have an interruption, a break in the line, meaning the metatarsal is short. Normal should look like this. So it should form a parabola without an interruption. Hallux rigidus, which is a common condition. If you took an X-ray, you would see no joint space, osteophytes. If you compare the first MTP joint with these ones, there is no space at the first MTP joint. Hypermobile first TMT joint, there is a way to measure it, but even if you didn't have a goniometer, if you stabilize the lateral 4 metatarsals and you find a lot of movement, it is hypermobile. And that's what it would look like on an X-ray. So the deformity is coming from this joint here, which is hypermobile, and it has got a little bit of subluxation on that X-ray. Small toe deformities can be different types, but we'll not go into naming them. And now we're going to look at a clinical case. I thought it will be easier to go through a clinical case. So we have a patient, and can we load the patient's history? Right. Oh, on the screen. So we have a gentleman here who is in his 40s, and Sudhir, he works as a driver for the chief secretary, I believe. So he's a VIP patient, and he is 50 by age. He's a driver. He's got no comorbid conditions, and he has presented with these feet. Just put it down. Yeah. So when we look at his foot from the front, can I khade ho jaiye? Just stand straight and toe pointing straight. Yeah, so it's always good to, as I said, roll up the trouser sleeves so you can appreciate. थोड़ा और ऊपर करिए, left side वाला. नहीं, trouser, pant, both sides, yeah. And can I see what he's showing? Okay. Zoom out, yeah. That's it. So there's not much, yeah, straight on. Maybe he can turn towards the camera. So yeah, that's fine. So when we look at him in that position, we start looking at the overall alignment, and there's not a lot to see on his overall alignment, but I thought he, on his left side, he had a little bit of fixed flexion in his knee, and there was some. And can you turn around? Yeah, and on his right side, the popliteal crease is a little bit obliterated. So he's possibly got some effusion there, although when I asked him, he had no symptoms. Can you go back to? Then when we look at his, then we want to make sure that he doesn't have any excessive bowing of his tibia. Abhi camera ki taraf. Sorry. So I don't see any excessive bowing of his legs, which is quite, I mean, I think I see it a lot in Scotland. I don't know whether that's a continental thing. And whilst we are looking at his legs, we are also looking at towards the lower part of his legs, he starts losing the hair. Like loss of hair. It is common to see hair somewhere around the middle of the dorsum of the midfoot. In his case, I couldn't see any. He's got a little bit of shiny skin. He's got brittle toenails. So keeping them together, I would call them as trophic changes, which would make me look for his pulses and his capillary circulation, because I would be looking at him as a surgical candidate. And of course, in his history, I would inquire about smoking as well, and diabetes, to go with those findings. Coming on to his ankle, rather than make him turn again and again, we'll just talk about his foot and then his hind foot. So looking at his forefoot, we can clearly see there is a lot of malalignment. Can you turn a bit more towards the camera so that it's slightly? Yeah, that's it. That's it. Okay. So when we look at his, his ankle does not have a deformity. His midfoot, looking at his arch, on his right side, his arch is lower compared to his left side. Left side is also lower. Both are low. And when we look at his big toe, which is the main joint we are looking at, there is severe valgus deformity. So the toe is pointing out. As well as the valgus, the toe is also rotated, so that's pronation. So that's something that one would see with a severe hallux valgus deformity, as in this case. And what has happened is, over time, his big toe has pushed on all the other toes. See, all the other toes are now also going into valgus. So this gentleman has severe hallux valgus with valgus affecting all the small toes on both sides. And the next thing that I would like to do is to see whether, Sudhir, do you mind if I ask you to do it? Is to see whether the hallux valgus can be corrected. So that's, yeah, I'm afraid the camera angle is such, but there is partial correction in the deformity. And the other thing we want to make sure is whether his MTP joint, stay there, Sudhir, if his MTP joint, can you come on the stage and examine him from behind? You can go on your knees, yeah, and look at the MTP joint movement. And you want to make sure that the joint is reasonably mobile. If with long-standing deformity, you can also have arthritis in that joint, and then again your management will change. And along with that, we also want to check, Sudhir, that his small toe deformities are flexible or not to some extent. And okay, and can I come over? So, okay. Can you hold that? Sorry. Yeah. So just if he lifts his leg up, and then on this side, we want to see whether he has any hard skin callosities, because what will happen is, as this toe becomes dysfunctional, all the weight gets transferred over to the smaller metatarsal heads, and then you'll start seeing them protruding from here, a bit like the knuckles in the hand. In his case, surprisingly, it doesn't have any hard skin callosities, which means that he's putting up with it pretty well. And that is most likely because he's not using shoes. They feel a little cold to me. But this joint is the most important joint. And it's got some crepitus, but no tenderness. So we have a severe hallux valgus. The tendon, I can see the EHL has dislocated, so it's not going to be treated with any conservative treatment. It will require some surgical intervention. It will require something that is going to make his foot into a shoe shape on both sides. So we then look at his x-rays. So we get weight-bearing x-rays. So I think the left side of the screen is the weight-bearing x-ray. And I had a picture of this kind of foot, the metatarsus adductus, in my presentation. He has got the same. So if you draw a straight line, it's not coming up. Yeah. So if you draw a straight line from the talus, center of the talus, then it should be where the first metatarsal should be. In this case, it is not, and so is the second and the third. So it's a typical pattern of metatarsus adductus. So if he was to have surgical treatment, it is very challenging because there is hardly any space to move his metatarsal in the way. It's almost like we need to remove one metatarsal away to create space, but obviously we are not going to do that. So his surgery would involve this metatarsal that would have to be shifted as close as possible to make it parallel to the second. It will probably require the same done to his fifth metatarsal, along with surgery to all the proximal phalanges of his foot. And that would be the surgical plan on this gentleman. That surgery is going to knock him out of action for a good 3 months. He's a driver and he needs to speak to his boss to get permission of leave for 3 months. If he can take 3 months off, then I would offer him surgery. Okay. Do we have a second, please? Oh, okay. So you can send him back. We had another patient until last night. Is gone now. But that's not the second one. Can you load the second case? But we can discuss it. I was hoping that we would be able to examine him as well, but we can't without the patient. Any questions so far?
Location of your osteotomy?
Will be the first metatarsal.
Not at the MTP joint, because the phalanx is totally almost subluxated from the...
So the osteotomy will be on either side of the joint.
Both sides, okay, yes.
Correct with a single osteotomy or a double level surgery in this case.
Sorry.
As well as something needs to be done for the hammer toes, which he has in the lesser toes. Otherwise, he'll still land up with pain in the lesser
So
toes.
that's what I said. The plan would be for the first metatarsal, it will be osteotomy on either side. So you have a osteotomy of the first and proximal phalanx of the first. With the second, third, and fourth, it will be osteotomy of the proximal phalanx of each. And then a wire is going through the MTP joint to hold it in a reduced position. And the fifth will also require an osteotomy to the metatarsal.
say if you're not able to get it fully corrected, would you have a plan B as a uh, proximal at a osteotomy or a fusion of the first metatarsal cuneiform joint?
Not in his case, because that's why I was saying it is important to identify the foot shape. If he had a planus foot shape, then you would do that. Because he's got metatarsal adductors, there is a limitation to how much correction you can get. The IM angle, the angle between the first and the second metatarsal, has to be huge for you to do the surgery that you are suggesting. But here, the problem is not the first tarsometatarsal joint, it is the adductors.
Okay, sure. Thank you.
Well, coming back to examination of the patient, would you like to examine the hind foot in this particular patient also and ask the patient to squat just to say that there is any tendo-Achilles contracture?
So, yes, so we forgot to turn him because of the camera. I was trying to avoid him. We were going to look at his hind foot. He does not have any significant deformity in his hind foot. With regards to the contracture that you are describing, you are probably referring to the tightness of the gastrocnemius, which is very important. But again, as I said, because of the situation of metatarsus adductors, it is unlikely that the gastrocnemius tightness is contributing to it. So he may have tightness, but that would not require any attention. As compared to somebody with a severe gap between the first and second.
Right, and for looking at the arch of the foot, would you like the patient to stand on one foot and examine him from the inner side?
So I don't think it adds much, whether you say the arch is low or it is semi-low or high. It is, for me, it's a visual thing. If I want to, then I would go to the medial side. I'll put my fingers through the arch, and then you decide whether you are able to cross one IP joint of your hand. And if you can, then it is reasonable. If you can't, then it is low. But that is, you can get the same information visually as well. But yes, it is a good practice.
Second case?
Yeah, go to my second case. So he was, well, if I show you the picture first of this man, so that's him. That's him. So we're talking about his right ankle here. What is the history? He's a 26-year-old. He's a delivery agent. And he came with a complaint of pain in his ankle for about 2 months. He recently changed his job. He has a deformity in his ankle since childhood. He had a history of an open injury to his right leg at the age of 2 years. He is now 26, so that's 24 years ago. He doesn't have any comorbid conditions. He's fit and well. When we look at him in a standing position, so that's the, if you can just focus on that picture there, what do we find? We find that he has a limb length discrepancy. So we made him lie down, we squared the pelvis, and then we measured the limb length. And it turns out that he is compensating for the shortening by tilting his pelvis, tilting his spine, and tilting his shoulders. So it all fits with shortening. He didn't have any obvious tenderness or swelling because he has a long-standing deformity. We can see that he has wasting of muscles, particularly the calf muscles. And he has this deformity. He has no neurovascular deficit. When we looked at him, we see on this picture here, that will be that looks like a severe valgus. His valgus is actually not coming from his hind foot. It is coming from just above his ankle. But because you see, if you look at the apex of his deformity, it is somewhere at the level of the medial malleolus. So it is above the ankle. If you look at his shape, foot shape from the front, it is pretty normal compared, given the deformity. So it is really well compensated deformity. There is some hypoplasty of all the toes on the right side compared to the left, but that's not very significant. So we are dealing with a case where there is severe valgus, and we get weight-bearing X-rays. Oh, that's his gait. Okay, so that's how he's walking. He's managing really well, but he's finding that with each year passing in his life, he's finding the medial malleolus pushing in and in and in. He can't wear shoes, so he just wears slippers or sandals. That's his X-ray. So this is, well, is that a weight-bearing X-ray? Sorry, we don't have, okay. So that's his X-ray, and that's his deformity. I mean, it is a very complex deformity, as we can see, and he's got a little bit of his ankle joint remaining. It's like a hinge joint that he's using. Can't comment on his subtalar joint, but a severe deformity, shortening. There is some recurvatum in his distal tibia. So this is going to, if he wants surgical treatment, then he is going to require a degree of lengthening. And in my view, probably better to take an opinion from somebody who's familiar with using the frame, Taylor special frame or Ilizarov. And if there is nobody available or nobody willing to take it, then it will require open surgery. If I was doing open surgery, I don't do frames, so if I was doing open surgery, I would do it in 2 stages. In the first stage, I would try and correct the deformity, probably with a distal tibia closing wedge, medial closing wedge osteotomy to bring the talus parallel to the tibia or the knee. And that is going to be challenging because it required 2 or 3 plane correction given the recurvatum. And subsequently, 6 months later, decide what next. Perhaps a fusion. Any questions about this?
I have one comment. Why this patient has developed so much of deformity? If you can look at the fibula, there is non-union in the distal fibula. So similar picture takes place in a pediatric patient who have congenital absence of fibula. And so it's a complex 3D deformity taking place at the ankle joint. You have rightly proposed Ilizarov or Taylor's frame could be used, but that again will have to have so many stages. So supramalleolar correction.
So he had an open injury, and the missing fibula is where he has a puckered skin. So I don't think it's a congenital absence. It's a post-traumatic.
I'm not talking about this patient. Similar deformities do take place in pediatric patients.
Correct.
With congenital absence of fibula.
Yeah.
Right. So this shows you grotesque amount of deformity, a surgical challenge to correct them, but then maybe 2-3 stages. Your opinion about it?
Thank you.
Oh, okay. Wrap up.
One imagines that any type of acute correction is going to have immediate and perhaps dramatic effects on the long flexor tendon tension, which could have secondary effects on his ability and to have a pain-free gait, and the potential for Ilizarov, as you mentioned, and gradual correction may perhaps allow that to catch up. It's a complex case, and the idea that the talus should come under the weight-bearing area of the limb is a key teaching point for our more junior doctors. At the moment, it's not under the weight-bearing area of the limb, and therefore he's getting the progressive deformity and medialization of the medial malleolus. So an ability to achieve that through the methods that you've suggested, Kalpesh, I think would be the most important aim.
Yeah.
The other that could have been thought of, that go for limb lengthening and then fix the tibiotalar and calcaneal joint. So then it could be more straight a solution.
Yeah, yeah. So I think eventually he will end up with a fusion, whether he gets Ilizarov first or open surgery. Thank you. No, that's me. Thank you.
What is the next presentation?